very much for the invitation. So I'd like to take this time to highlight a little bit of what we do at our center, which is somewhat based on an evidence-based approach. And I say somewhat because the amount of evidence out there is lacking at this time. However, bariatric surgery is one of those procedures that's very amenable to enhanced recovery techniques. One of the things is there's an algorithmic approach to the surgery. You do the same thing every time. And really, if you think about it, there's a lack of pathology. These patients are not acutely sick. These patients are chronically sick with many illnesses and diseases. But in terms of an acute illness, they're coming into an elective surgery fairly healthy. In terms of lack of pathology, the only things that we really have to worry about is the amount of body wall fat, the amount of visceral fat, and hepatomegaly. But other than that, it's extremely rare to have any surprises regarding the anatomy. So we can do the same thing every time. The challenges with bariatric surgery have been dealing with the obese patient. And that includes dosing of medications, that includes mobilizing and moving the patient, dealing with complications, spotting those complications. And I think those are the biggest advancements that have been made in bariatric surgery that is now allowed for enhanced recovery techniques to progress. The way that I think about bariatric surgery and the way that I tell my patients is that we're going to take normal anatomy and we're going to make you abnormal. And so that's one of the reasons why it's a fairly standardized approach to surgery. What we've done with our patient flow is we've taken a flow chart and we've mapped out everywhere the patient is throughout the process. And this goes on for 3 pages just to show you kind of as the patient progresses. So the reason we did this was to show what the patient does at each physical place of the hospital, and then that would allow us to see who is responsible for that phase of the patient's journey. It's a little bit difficult to see here on this slide, but you can see it starts in the physician's office, and then it goes on to the pre-op area, and as the patient goes through testing, et cetera, moving into the operative area and then the post-operative area. And we have very defined tasks that the patient has to do and that the nursing and other professionals that are involved with the patient's care are responsible for. So in terms of the team approach, and you've heard it many times today, the theme, we have the specific tasks allocated to each team member during the course of the patient's journey. And this extends from the preoperative visit all the way through to the postoperative course. And I have a few slides here. The same thing we did for informed consent. And I think this is one of the major things that we focus on in terms of bariatric surgery, is that we spend a lot of time in education. The first time that we have contact with our patients is at an information session. These are a big group meeting. We go over the surgeries. We also go over the complications. We give the patients an idea of expectations at that time. So that's the first step of the informed consent process. Then the patient will meet with us in consultation, where we go over the specifics related to that patient's medical history and surgery. The patient will then go for testing, will return for their preoperative visit, which is scheduled about a week or 2 prior to their surgery. And again, we go over the informed consent process. But even before they've reached that point, they've attended other areas in terms of pre-admission testing, consultation with anesthesiologists as necessary, and other testing with their providers, be it cardiologists, endocrinologists, or whoever else is involved in their care. So we've spent a lot of time educating the patient. And what we did was we designed something that we call a prep class. And in this prep class, it's a 3-hour class for all the patients that will be undergoing bariatric surgery in the next 2 weeks. And we spend that time giving them step-by-step directions on what to do, what to expect. And this 3-hour class involves nursing. And the nursing is involved in really the minutia of their stay in the hospital. Pharmacists will talk about medications that the patient will be taking, both post-operatively and how they're going to take their medications once they leave the hospital upon discharge. And then we have the nutritionists that discuss both the preoperative nutritional guidelines as well as diet progression in hospital and diet progression outside of the hospital. So very intense class. One of the things that the nurses go over is the common complications, the signs of these complications, what to look out for, how to alert your care providers, when to call, and again, it's a very intense class. And then we also give the patients a booklet outlining all of these complications and what to expect. Again, the theme is spending a lot of time on preoperative education. Once they've done that prep class, once they've done their pre-admission testing, clearance by anesthesiology, et cetera, then they finally come into our office, and at that time we go over it another time and discuss with the patient, make sure that they really have a good understanding of the surgery that they're about to have and what are the potential pitfalls of their recovery. We also set expectations at that time with regards to pain management, with regards to mobilization, with regards to early feeding, and with regards to discharge. So a very standardized approach for all of our patients. At that preoperative visit, we also give our patients a couple of things. One, a prescription for all of the medications that they're going to require upon discharge from the hospital. So it's not something that we do at the hospital time. We do that preoperatively. We give them pain medications. We give them their PPIs. We give them their vitamins. And one thing that's not on this prescription is their antiemetics. So we prescribe some Phenergan, some Zofran. We basically stock up the patient, tell them to go fill their prescriptions that day so that upon discharge, those prescriptions and those medications are ready and waiting for them at home in case they need them. This significantly will help cut down on readmission for pain purposes or nausea control. At that same preoperative visit, we also give the patient 2 years worth of follow-up. So we're treating these patients almost like an obstetrician clinic where we know exactly what's going to happen, and we give them their follow-up for 1 week, 1 month, 3 months, 6 months, 1 year, 18 months, and 2 years. So when the patient leaves that day, even before they've had surgery, they know exactly all of their follow-up, all of their diet progression, and have their pain medications as well. We designed a booklet, and the booklet has a day-to-day, step-by-step diet progression designed by our nutritionist with pictures that gives the patient very clear guidelines on what to eat, when to progress, and we reaffirm those guidelines upon all of those follow-ups that we have. Also during the preoperative visit, we discuss the NPO guidelines, and this has been a fun challenge with the hospital, I'll say, getting everybody on board. But what's made this very relevant is the buy-in from our anesthesiologist, the buy-in from the nursing staff at the pre-op area, and the offices that are doing the preoperative education for the patients. Basically, we tell the patients no solid food after midnight, and you can have clear liquids up to 2 hours before the procedure. We're very clear on what the clear liquids are supposed to be. Now, despite being very clear here, we've already had a couple of speed bumps, and several weeks ago, one of my patients had orange juice at 4 o'clock in the morning prior to her procedure. She's a diabetic, post-liver transplant. When she came into the hospital, they were going to delay her surgery and give her a 6-hour window. So we fought about it, and I showed them, the guidelines that I helped design, that the anesthesiologist helped design. We asked the patient, she said there were no fruit pieces, which is an important aspect of clear liquids. The problem was that on our sheet here, orange juice wasn't listed. Apple juice is listed, coffee is listed, tea is listed, but orange juice is not. So the anesthesiologist in charge did a literature review, Googled everything possible, and there was no indication of orange juice being listed in enhanced recovery protocols. So I had to delay the case, and do the 6-hour NPO window, which was ridiculous. But in any case, it's otherwise worked out very well. We've had a couple of fights. One of the patients had Jell-O and nearly got the case canceled until I brought up this piece of paper and said, look, gelatin without fruit pieces is okay. So it's been okay. So just having this sheet of paper on our hospital letterhead has made all the difference. In terms of urinary catheters, we've made a lot of progress in the last year. And the guidelines that are listed here are official hospital guidelines. Now, one thing I didn't put on this slide is that this really only applies to mastectomy and bariatric surgery. So we've had difficulty getting buy-in from the rest of the services. And one thing that we do is, I've actually pushed this, we don't place any urinary catheters for procedures that we expect to be less than 3 hours. That's our cutoff there. But otherwise, we just have the patient use the restroom as they're being moved to the operating room, and rarely do we need to place a catheter. When I'm telling patients that you won't need a catheter for surgery, the smile on their face, the anticipation, they're very excited about that. So that's been a very good patient satisfier for us. The number of patients that have had urinary retention has been looked at. It's extremely low, maybe 1%. And I think from the point of view of risk-benefit, it really has worked out that we haven't required any urinary catheters for our surgeries. Now, something that does occasionally happen at our hospital, and especially with my surgeries, is that if we're doing a revision surgery, those tend to go a little bit longer. If it goes over 3 hours or 4 hours, we will do in and out catheterization at the end of the case before the patient has been extubated, and still not use the catheter. In a patient where a catheter has been placed for an extended case, we will generally remove it upon intubation so that the patient can be transferred to the PACU area without a urinary catheter. Intraoperative, we've designed a menu of multimodal pain therapy, and again, this has been in conjunction with our anesthesiologist. All of the patients receive Toradol, Tylenol, and then fentanyl, according to the anesthesia. All of the wounds are infiltrated with bupivacaine, and then we also place that preperitoneally when we're placing our trocars under direct vision. The issues with Toradol have been bleeding, and I'll talk about that in a second. IV acetaminophen cost is always an issue. We're unable to prescribe that routinely on the floor, but intraoperatively we can easily give one dose, and actually the cost is about $60 at this time. Other things that we do is administer anti-nausea agents like Decadron. We use a scopolamine patch for all of our sleeve gastrectomy patients because they tend to have a higher incidence of postoperative nausea. For the issue of goal-directed therapy, IV therapy, that's been a little bit controversial. We've seen the benefits in colorectal. We've seen the benefits in other procedures. When it comes to bariatric surgery, because of the decreased intake that the patients have postoperatively, there actually may be a role for more IV fluids intraoperatively in order to have the patient well hydrated in the first several days postoperatively. It doesn't seem to impact anastomotic edema. There's a potential where it may be impacting edema in sleeve gastrectomy patients, but generally we limit the amount of IV fluid to about 1 liter during a procedure, simply because the procedures are quick. They're under 2 hours, and you can't get in more IV fluids than that. But post-operatively, we do place the patient on a maintenance dose. I'll get to that for a second. There's been a lot of concern about using Toradol, ketorolac, for pain control intraoperatively because of platelet destruction and potentially higher bleeding rates. There was a meta-analysis that was performed and looking at the use of ketorolac versus control groups, and the bleeding rates were essentially the same. The limiting factor of this paper, I would say, is that they looked at a lot of abdominal procedures, whether it was upper abdominal, not really classified, open cholecystectomy, abdominoplasty, hysterectomy, things like that, but no real emphasis on bariatrics. And the problem with bariatric surgery is if you're doing a sleeve gastrectomy, we use 6 60-millimeter cartridges. So that's a fairly long amount of staple line. In a gastric bypass, I use a total of 7 cartridges. So if you add up all of those staple lines, there is a higher potential for bleeding, and I think that is a concern, especially considering that we give every single one of our patients 40 milligrams of Lovenox in the holding unit before they've even started the surgery. And right now we are looking specifically at our bleeding rates, but they have been in line with national standards. So we've continued this standard use of Toradol for all of our patients. Postoperatively, the rule is no tubes, no drains, no scheduled x-rays for our patients. I'm not going to go over all of the data on it, but it's pretty clear that standardized upper GIs for bariatric patients has a very low yield of finding leaks in patients where it's not already clinically evident. So there's no use in getting routine upper GIs postoperatively. That's been found to delay the onset of early feeding. We've discussed drains, we've discussed tubes, catheterization. So again, that's been the protocol that we've used for all of our patients. We start early feeding. It's 2 hours postoperatively. So as soon as the patient has been admitted to the floor, they will start to get their full liquids. Now, the rationale behind full liquids versus clear liquids is, it's not the consistency of the liquid intake that's going to cause a leak. If you're going to leak with clear liquids, you're going to leak with full liquids. So you may as well start the patient on some substantial intake at that point. We also have educated our nurses that as soon as the patient gets to the floor, they're ambulating. If they're in bed, they're using SCDs, they're getting their Lovenox, but we do want the patients ambulating. We give them goals to go around the floor, and everyone is on board with that. I did discuss the IV maintenance. We do keep it at 125 cc's an hour generally for most patients, and we do place all patients on a morphine PCA. That's in addition to scheduled Toradol for the first 24 hours for our patients. Now, in terms of early feeding, we did a study at our institution looking at the effect of early feeding on discharge. And as you can see from the title of the study, it does reduce the length of stay. We looked at a 10-year period, and you can see the total number of 3,000 cases over that period, 8-year period. And most of the cases that we do at our hospital involve gastric bypass. Now, all of the revision cases, which is also a big part of our volume, were removed from this analysis, so looking only at primary gastric bypass and sleeve gastrectomy patients. Early feeding was defined as PO intake on postoperative day 0. Delayed feeding was defined as postoperative day 1 or later. And what we found was that the mean length of stay for the patients that received early feeding reduced length of stay by about 20.5 hours, which essentially 1 day earlier. So no difference in complication rates between the two groups, no difference in leak rates, no difference in really anything else. So early feeding is something that is useful for recovery and useful for a decreased length of stay. On postoperative day 1, when our residents and fellows round in the morning, we have a very standardized order set. So you type in bariatric into our computerized order entry, and the standardized order set pops up with IV maintenance, blood sugar control, PO intake, the medications that we described for antiemetics, pain control, et cetera, et cetera. We have a post-op day 1 protocol as well. It's the HEPLOC, the IV, DC, the PCA, convert all medications to oral and start preparing the patient for discharge. Now, the patients know that they're going home post-operative day 1, and so they're prepared for it, and they're waiting. They're waiting for the bariatric nurse to come by to discuss any outstanding issues. The nutritionist comes by and visits every patient, goes over the diet progression that they're going to have at home, and the pharmacist comes by as well to discuss the route of administration for all of their medications. And then we generally have a discharge planned before 11 o'clock that day. Now, the concept of early discharge was really pioneered by a group in Dallas, and I remember hearing about this in my fellowship and thinking, that's crazy, sending patients home the next morning after a gastric bypass. But if you look at their data, it's actually very convincing. 2,000 consecutive gastric bypass patients, and 84% of them were discharged within 23 hours. A very low readmission rate, and complication rates that are in line with big meta-analysis and outcomes research. The mortality, they had 2 patients that endured a mortality. Both patients had the mortality in hospital and were not discharged. So this same group is discharging patients with sleeve gastrectomy same day, which I'm going to say I think is a little aggressive. And the reason for that is that we have to consider if the patient is going to have a complication, when are they going to have the complication? And I think what we've confirmed is that if patients are able to tolerate oral diet and liquid intake on postoperative day 1, it's unlikely that they are going to have many problems going forward until their postoperative visit, day 7 or 8. However, with our patients with sleeve gastrectomy, we find that no matter what's happening on post-op day 0, postoperative day 1 is really the crucial time. It's at that point that postoperative edema or nausea really sets in, and it becomes evident, is the patient going to be discharged on postoperative day 1, or will they require a slightly increased length of stay? So discharging patients on postoperative day 0 from sleeve gastrectomy, even though it's a less invasive or less complex operation than gastric bypass, may not be a good idea. Here's our results. So we look at our outcomes on a quarterly basis. And the things that I will mention is we don't have as good readmission results as the group that I just discussed, but we have a very high number of revision surgeries that we do every year. So almost as many revision surgeries as gastric bypass surgeries. We treat our revisions pretty much the same as our primary surgery. So the same standardized protocols for our revision patients. And the thing that I will point out is that our outcomes are good, and our length of stay, when you take away the 5-day outliers, generally has remained under 2 days and well under 2 days using these enhanced protocols. And one other thing that we look at is our length of stay distribution, and in this case, the red is good, and this pie chart is similar to the other pie charts that we've seen, and we look at this again on a quarterly basis, how many of our patients are discharged within postoperative day 1 or 2. And again, it's the majority of patients, even our revision patients, you can see that 2/3 of them are being discharged within 2 postoperative days. Now, I will say this isn't for every patient. This isn't for patients in heart failure. This isn't for our post-transplant patients. This isn't for our hemodialysis patients that are undergoing gastric bypass. But even then, we have protocols for our higher risk patients. So for example, with my renal failure patients in hemodialysis, what I do is the patient has hemodialysis the morning of surgery. They'll have their gastric bypass in the afternoon. They will start their feeding on postoperative day 0. Postoperative day 1 will be spent really just hanging out with a planned discharge at postoperative day 2 after they've completed another round of dialysis. And with our patients, which it's a little separate research study that we've got going on, the length of stay has been 2.4 days for our patients there. So we've maintained that enhanced recovery protocol even for our high-risk patients. So in conclusion, some of the tips for successful implementation, we've discussed this all day. It's part of the theme of the day. I think one of the most important things is an adequate patient selection. I've detailed the patients that maybe don't fit into enhanced recovery protocols. Those would be the patients with acute illness or chronic illnesses that are going to be perhaps limiting the ability to mobilize early or other need for prolonged observation in the hospital. The pre-op education and preparation, I think, is a key here. I think it's putting the recovery and information in the hands of the patient and having them understand what to expect is key. The third thing, minimally invasive surgery, I think that's a given. About 98% of the procedures that we do are laparoscopic, and one day I don't think we'll even be saying those words, it'll just be surgery. The multidisciplinary team with a buy-in from nursing staff, from anesthesia, and from all of the surgeons is essential here. Obviously multimodal pain control, reducing surgical stress with hydration of the patient, and preoperative carbohydrate protein drink. Early mobilization and feeding, and lastly, standardized protocols that everybody can follow. Thank you.